Okay, so this is a continuation of the live streaming for the second day. So we are talking about immune cell that has both memory and specificity. And the options here include option A, B cells, option B, NK cells, that's natural killer cells, and then option C, T cells. So which of them has both memory and specificity? Option D is macrophage. Let me include it in the question because that may change things. I don't know. Option D is macrophages. Option A, B cells. Option B, NKC. Option C, T cells. Option D, macrophages. So the one that has immune cell that has both memory and specificity. Yeah, I think a lot of them actually has memory. So it's that specificity that, is going to rule out a lot of cells. Specificity will rule out NK cells. Specificity will rule out probably macrophages because they are not that specific. So it will now be a battle of B cells and T cells. All right. So let's see. The class is torn between A and B, A and C. Yeah, macrophages does phagocytose pathogens. Okay, so basically any pathogen they see, they can phagocytose it. NK just recognizes and kills infected cells, so they are not that specific. T cells have specific receptors. Okay, so let's go with B cells then. So you know that B cells also remember the antigen because of B cells produce antibodies actually. So they have a memory, strong memory to remember the antigen and produce antibody that will bind to it for a long time. Okay. So let's go to another question. The following are advantages of CT scan, except this one is a simple question. And put aorta and D. Not all right. So advantages of CT scan, except A, no risk of radiation. B, patient is not moved during the procedure. C, aorta, that's all of the above. D, none of the above. So what do you think? Dr. Chrysogonus, why do you keep unmuting your mic when you know you are playing something in the background? Okay, so let's attempt the question so that we can move to the next. These questions are questions from the last exam, so they are very fresh. when you go for an exam, the first thing you must have an open mind. The essence of what we are doing here is to give you an idea of the kind of questions. So you can see that, so for some of you, you hold your update slides, you hold it like it's a dogma. Okay, you just say, they set questions from update slides. Can you see these questions? Do you think you find them in any update slide? So if you've never like looked at the past questions and you are just reading slides aimlessly, the exam will shake you, because like you are going to see a lot of things that you will not have read anywhere except you have been directed to read them. Okay, so you pay very rapt attention to what we are doing. So of course, CT scan is just an X-ray that was taken in multiple directions. Okay, uh, computed and now put into a computer to mix it up and turn it into a 3D or 4D image or 2D image, depending on the situation. So it's called computed tomography. So it's an X-ray. It requires radiation. On the other hand, it is MRI that doesn't require ionizing radiation. It uses magnetic resonance. So it uses magnets, right, to produce its own image. Then the one that doesn't require any form of any, radiation at all is ultrasound scan, which spares the patient from any form of both magnetic and non-magnetic radiations. So obviously there's a risk of radiation, and that cannot be an advantage of CT scan. So be careful with an accept. When you see an accept, it means you are looking for the negative thing. So for those who are still in doubt or who don't understand, I'll put it here so that to be shown on the screen. Patient may need to move during the procedure. Okay. This one said patient is not moved during the, well, patient may need to move depending on like what patient may rotate to capture different aspects. Okay. And they provide detailed images, they are fast, and they are available. Let's not just say widely available, because they don't say in Nigeria we did. Okay, so following are causes of acute stroke, except, let me put it up for you. Question says the following are causes of acute stroke, except A, subarachnoid hemorrhage, B, subdural hemorrhage, C, cavernous sinus thrombosis, D, basal ganglia infarcts. So which one is not a cause of acute stroke? Let's answer, please, so that the class will soon end in the next 5 minutes. So you guys should hurry up so that you can see how many questions you can squeeze in within that time frame. Subdural hemorrhage, Dr. Hillebo and Harrison. Who is saying that they cannot hear? Dr. Oku, you should click on the image. If you look at the list of this thing, you'll see the one that relates to the video, the one I'm showing on the screen. Click on it. Anybody that you click here, you will see it will become the central part of your screen. So go scroll through those lists of this thing. You'll see the one that where I'm sharing my screen. Click on it. It will now show on the center of your screen. That's how you get to see everything. Okay, someone thinks it's cavernous sinus thrombosis. So let's see what everybody has to say. Stroke means that the blood vessel that supplies the brain is I think I don't agree with this. Okay, so the answer, my screen is being shared. Some people are seeing my screen. I'm very sure of that. You have to click on my screen to make it bold on your own screen. Like click on it, it will now centralize on your own screen. Dr. Oluwaseun. So I think it's subdural hemorrhage because that's like outside the brain. Okay, that's it will not it's going to lead to a bleeding outside the brain. Okay, subdural. Let me show you an image. Subdural hematoma. Is subdural hematoma. Okay, so there's the arachnoid matter, there's the pia matter, there's the dura matter. Okay, so there are two places where bleeding, which is outside the brain, can be. It could be epidural. Okay, epidural means it is outside the dura mater, so it's between the skull and the dura mater. So wait, let me show you. I like to make things. So yes, let me use this one. Let me use this one. Okay, so epidural means it is outside the brain, outside the dura mater. Okay, so it's external to the dura mater. So it's between the skull. This is the skull of the patient, and this is the blood, and this is the dura mater. Okay, so that's epidural hematoma, and this one occurs when there is injury to the temporal arteries that are on the side of the head. So if a person, if for example, someone hits a patient with the bat on the side of the head, a patient falls and hits the side of the head. If patient is bleeding, it's going to be that epidural hematoma, right? And there's something about this epidural hematoma. Uh, it's very bad. Okay, so someone could have an RTA, hit the head, rupture the temporal arteries, and then bleed into the epidural space and have this hematoma there. But the patient will have initially lose consciousness and then wake up again and continue like everything is normal. That's because the brain is trying to compensate. If you know the Monro-Kelly doctrine, I'm just saying some of these things so that next time when you hear it, it will make more sense. So about the Monro-Kelly doctrine, which says that the brain, the pressure in the brain is a combination of the the intracranial pressure. Okay, for you to get the intracranial pressure, you have to consider the brain tissue, the blood pressure, and some other things, the CSF. Okay, so it's a combination of all those things. So because there's an external body, which is the blood that is bleeding into this brain, the brain will try to make up for it by reducing the quantity of CSF, by reducing the blood pressure, or increasing the blood pressure so that blood can still reach the brain, just trying to make up for it. But with time, if this blood keeps occurring, it will not be too much and it will lead to what is known as coning, because this brainstem will now herniate through this foramen, okay, herniate outside the foramen, and that's basically death. Okay, so that's what happens in a patient. There's something called the lucid interval, where the patient at the time of trauma, the patient will be unconscious. Then the patient will now wake up and have something called the lucid interval, where the patient is awake, like everything is normal. So someone had an RTA, patient lost consciousness, now woke up and be like, "Hey, thank God, oh, he's awake. Wow, thank you, thank God, oh, hey, welcome back." Then they now forget to go to the hospital, or even if they're in the hospital, if it's a doctor that doesn't have this information, the doctor will think, everything is normal. My patient is now okay, but it's just a matter of time. In the next 30 minutes to 1 hour or 2 hours or 3 hours, whatever time it takes for that compensation to be overcome by this bleeding, the patient will now enter the second coma. That's everlasting coma now. It's no longer, you're not going to be able to do anything. So if you see a patient that has a brain injury, had consciousness, now woke up, please hurry up and go and do a CT scan so that you see if this patient has bled into the brain. Okay, that's epidural hematoma. Then the second one is subdural hematoma. Okay, which means that the patient has bled under the dura mater, as you can see here. Now, subdural hematoma, it looks like the lens is called biconvex. Okay, so biconvex appearance. Okay, that's the epidural hematoma. This one looks like half a moon. Okay, so lenticular. It looks like a moon, crescentic rather. It looks like a piece of a moon that is just there. That's subdural hematoma, and this one usually occurs in elderly patients who just have a minor trauma, or maybe a minor fall, or a minor trauma, or just something that the patient may not even remember that they even had any trauma or any injury at all. Meanwhile, they have had a very serious injury in the brain. Okay, that's what occurs in subdural hematoma. Okay, so on CT scan, it just looks the same way on CT scan. I'm sure if I look for a CT scan image. Uh-huh. So you can see subdural is more widespread. Subdural is more widespread. See, it's all over the place. Okay. On the other hand, epidural is more localized. That's why it's lenticular. Okay. Why this one is crescentic. All right. So I believe we've done some justice on this particular topic. Do you have any questions about this topic? Okay, let me give you the last one for the night. The nerve that mediates the jaw reflex. This one is a very simple question. The nerve that mediates the jaw reflex. Option A, facial nerve. Option B, trigeminal nerve. And option C, glossopharyngeal nerve. Please, if you are here, endeavor to attempt the questions. It's very, very important for you. It's part of the learning process. It's part of the learning process. Dr. Oko, you want to answer the question? You can speak if you want to answer the question. Sure. There's also a button here that you can use to raise your hand, right? Once you just click on it, it will be that you have raised your hand. It will show to everybody that you have raised your hand. Okay, like if you want to speak, and I'll call on you to speak. Okay, so go ahead, Dr. Oku. Dr. Oku, you can unmute yourself. If it's a question, just wait, answer this question, and then we can produce. But if you want to attempt the question, you can go ahead and speak. All right. So there's someone here that didn't put the name. Please, tomorrow, if you're coming, when you get to that screen where you need to put your name, please put your name, because I'll be removing those who did not put their names, because I need to be able to identify my candidates. If you're putting your name, put something that's the same thing that you used on Air Clinic, so that I can identify you. Okay. So you guys think is option what? Option B is taking the cake here. Trigeminal nerve. Okay. Okay. Let's see what everybody thinks. Trigeminal nerve. So trigeminal nerve is majorly sensory actually, and then a little motor for the muscles of mastication. And we know that this reflex is related to what was this joint? TMJ, temporal mandibular joint at the angle of the jaw. Okay, so that's where the jaw reflex comes from. Okay, tell me about the jaw reflex. So specifically, the mandibular branch of the trigeminal nerve is involved in uh, this jaw reflex. So it's an important clinical sign that is used to assess the function of the trigeminal nerve and the masseter muscle. Abnormalities in the jaw reflex can indicate a variety of conditions like trigeminal nerve damage, masseter muscle weakness, temporal mandibular joint disorders. Yeah. So clinical testing, how is it done? You apply a gentle pressure to the masseter muscle with a reflex hammer. Patient response to the stimulation should be a contraction of the masseter muscle. Reflex can be graded as follows: normal, okay, normal, diminished, or absent. So that's basically it about the jaw reflex. So the mandibular branch of the glossopharyngeal nerve, which is V3. So mandibular branch of the trigeminal nerve, which is V3, is involved in jaw reflex. In fact, anything around the face, you know how the division of the trigeminal nerve from the angle of the eyes upwards, that's V1, that's the ocular branch. Okay. Then between the angle of the eyes and the angle of the mouth, that's V2. Okay. that entire skin around there is controlled by V3. That's the second branch of the trigeminal nerve, also known as the maxillary branch of the trigeminal nerve. Then below the angle of the mouth, that's V3, okay, controlled by the mandibular branch of the trigeminal nerve. Okay, so do you have any questions for today before we call it a night? Is there any question? Anyone with a question? Go ahead, Dr. Oko. You can unmute yourself. You can unmute yourself and talk now.
Good evening, Chief. Good evening, Chief.
Good evening. Who is speaking?
Is Dr. Ogbuefi online?
Okay, Dr. Ogbuefi.
Yes, sir.
All right.
Thank
Go
you.
ahead.
Thank you so much for your wonderful presentation, sir. I really appreciate it. Please, for that of question number one,
You're welcome.
that the causes of food poisoning without GI colonization. I don't really get the best option for that particular question because I choose preferences. I don't know the one that is the best option for that particular answer, sir.
You said the best option is Clostridium
No,
perfringens.
I say I choose Clostridium perfringens, which is B, but I don't know the one that
Yes.
that suits the question.
I said the correct answer is Clostridium perfringens. The question is asking for the cause of food poisoning without GI colonization. So Clostridium perfringens does not directly colonize the GI.
Okay,
What
sir.
it does is to release toxins.
Okay,
So
sir.
it is the toxins that destroys the GI and leads to the food to the the food poison, the vomiting and everything, the inflammation, right?
Okay,
It's
sir.
not the organism itself. It's the toxins that are released, exotoxins that are released by the organism that does that.
Okay.
In fact,
Okay.
every type of Clostridium, they release toxins, okay? Because
Yes, sir.
tetanus is actually a Clostridium, so it's called Clostridium tetani. That's tetanus. And it releases a toxin called tetanospasmin and tetanolysin. That's tetanus, okay? So still relate that same thing. Clostridium perfringens is a cause of food poisoning, okay? It releases a toxin. Uh, we saw the name of the toxins earlier. Let me see if I can scroll up to find them. Like two different toxins that are involved in perfringolysin, that's PFO, and alpha toxin. So these are like lytic toxins that break down the cell membranes and then lead to tissue damage. So that's why it's not a direct GI colonization. It's the toxins that do the damage. All right. That's why that's the answer.
Okay.
Understood?
Yes, sir.
All right. Do you have any other question? Okay. So is there any other person with a question before we call it a day? All right. So if there is no other question, we'll call it a night. Thank you guys for coming around. I'll end the live stream here. Dr. Oku, you want to say something? Just unmute your mic and speak.